Good morning. I am Shanja Hussain. Today my topic is anticholinergic drugs. Definition: anticholinergic drugs are those which blocks action of ACH, that is acetylcholine, on autonomic effectors and in the CNS exerted through muscarinic receptors. We already know that cholinergic drugs have two receptors, that is nicotinic and muscarinic. Although nicotinic antagonists also block certain action of ACH, acetylcholine, they are generally referred to as ganglionic blockers or neuromuscular blockers. Atropine is the prototype drug of this class. The drug of choice here is atropine. Now, next we have classification. In the first photo, anticholinergic drugs are classified into two types, that is according to the receptors, that is antimuscarinics and antinicotinics. Antimuscarinics are also known as parasympatholytics. Now, parasympatholytics are alkaloids, that is naturally occurring, and synthetic atropine substitutes. Then antinicotinics can be ganglionic blockers and neuromuscular blockers. Now, in the second one, we have all the names. Alkaloids are atropine, hyoscine. Semi-synthetic drugs are ipratropium bromide, tiotropium bromide, hyoscine, butyl bromide, atropine, methonitrate. Synthetic drugs are midriatics. We have cyclopentolate, tropicamide, anti-secretory, antispasmodic, quaternary compound, tertiary amines. All these are here in the classification. Glycopyrrolate, oxyphenonium, these are quaternary compounds. Dicyclomine and pyrenzepine, this is tertiary amines. Vesicoselective, that is oxybutynin and flavoxate. Anti-Parkinsonian, trihexyphenidyl, that is benzhexol, procyclidine, bipridine, benztropine. Others, tricyclic antidepressant, that is TCA, we call it in short, and phenothiazines and antihistamines. So this was the classification for anticholinergic drugs. Parasympathetic, also called atropinic, also we can say them. Next is mechanism of action. It blocks the muscarinic receptors. Here we are basically talking about muscarinic receptors. So it is anticholinergic. So basically it blocks muscarinic receptor. In the next slide, I have given some the mechanism of action. It is almost similar to the same like cholinergic drugs, but let me again repeat it. So cholinergic neuron we have in green pre-synapse, and in yellow we have the post-synaptic, and in between the white junction is called a synaptic cleft. Now you can see the cholinergic neuron depicted with the red arrow. Here there is calcium channels, that calcium channels enter from the those sides, and the cholinergic neurons are already in the vesicles. We can see in the green color neurons in the red color ball. So and through all the some enter through calcium, some enter through all the channels here and there. And we also have a autoreceptor channel, that is in shown in green. So here we can see that the calcium ions enter, and they start forming with the vesicles, and then the vesicles burst, and the neuromuscular that neuromuscular it burst, and the it is transferred, neurotransmitter is transferred to the synaptic cleft. Now at the synaptic cleft there are present Anticholinergics like atropine, dicyclomine, benzotropine. So they already have come and binded to the muscarinic receptor. Basically, here you can see in purple there are many types of muscarinic receptors: M1, M3, M5, M2, M4. So these phospholipase C, adenyl cyclase, K plus conductance is potassium conductance. So here we have excitatory action for M1, M3 and M5, and M2, M4 show inhibitory action. Okay, they increase M1, M3, M5, they increase the action of phospholipase C, so it shows excitatory action at the end. M2 and M4, they decrease the action of adenyl adenylyl cyclase, and potassium conductance is increased, so it shows inhibitory action for muscarinic receptors. Here in nicotinic receptor, that opens sodium and calcium channels. We also have anticholinesterases. Here they can be used as galantamine, paralidoxin, then neuromuscular blockers like curare, then LEM autoantibodies. So basically here in this diagram, this is a very well labeled diagram. We are shown the mm, effect of anticholinergics on muscarinic receptors at the base of it. Here in this position we can see the anticholinergic drugs are binding with the muscarinic receptors, which in turn is stopping the acetylcholine to bind. So they are showing two types of actions, that is excitatory and inhibitory. So that was the mechanism of action for anticholinergic. Now we come back to the last slide where we are talking about the pharmacokinetics. So before the pharmacokinetics, let's talk about the pharmacological action. Here I have given it on 8 things. One is eye, another is CNS, then we have secretion, then we have smooth muscle, that one of them is stomach, then we have body temperature, local anesthetics, then cardiovascular system. So one by one, let's see all of them. Eye, dilation of pupil, mydriasis, and increase IOT is intraocular tension. CNS is central nervous system. Stimulant action in low doses produces only peripheral effects because of the restricted entry into the brain. So the entry is restricted, BBB जल्दी से क्रॉस नहीं कर पाता है. सिक्रीशन, डिक्रीज सिक्रीशन, अब किस चीज़ का सिक्रीशन डिक्रीज करता है? सलाइवरी, लैक्रिमल, ट्रैकियोब्रोंकियल, गैस्ट्रिक, स्वेट. Skin and eye become very dry. Talking and swallowing may be difficult, but milk secretion is not affected. CVS, we have tachycardia, that is high heartbeat due to M2 receptor blockage. M2 रिसेप्टर को ब्लॉक कर देता है, इस वजह से टेकीकार्डिया हो जाता है. ब्लड प्रेशर, एट्रोपिन डज नॉट हैव एनी मार्क्ड इफेक्ट ऑन बीपी बिकॉज इट इज़ नॉट इन्वॉल्व इन द मेंटेनेंस ऑफ वैस्कुलर टोन. हाई डोज अगर दे दो तो बीपी कम हो जाता है. स्मूथ मसल, smooth muscle is gives relaxation like bronchi, urinary bladder, and stomach tone. Now in smooth muscle there is a part, stomach we have spasm or contraction that can be relieved. Constipation may occur, and peristalsis is only incompletely suppressed because it is primarily regulated by the local reflexes and other neurotransmitters. Other neurotransmitters are 5-HT and enkephalin. I don't remember what is the name of 5-HT, but I will tell you in the comment section. And hormones. So this was all about smooth muscle, and one of them is stomach. The next is body temperature, rise in body temperature due to inhibition of sweating. And local anesthetic. Local anesthetic, mild anesthetic action on cornea. Cornea is in present in eye. So that was the pharmacological action. Now we come back to pharmacokinetics. Rapidly absorbed in GIT. GIT is gastrointestinal tract. Atropine and hyoscine, that is alkaloids, those are rapidly absorbed. Freely penetrate to cornea. Passage across BBB is somewhat restricted. BBB is blood-brain barrier. About 50% of atropine is metabolized in liver and rest is excreted unchanged in urine. T-half is half-life is 3 to 4 hours. Hyoscine is more completely metabolized and has better BBB penetration. Atropine sulfate, we can give the medicine atropine sulfate. There are two types of atropine sulfate, one is with F and one is pH. So that one with F can be given parenterally and topically, and with that pH one can also be given parenterally. And atrosulf 1% eye drop, 5% eye ointment. Hyoscine hydrobromide 0.3 to 0.5 mg oral we can give, IM we can give, and also as transdermal patch. Combination of atropine and analgesics and antipyretics are banned in India. This is an important point. So that was about the pharmacokinetics, mechanism of action, pharmacological action. Then we have the side effects. Here you can learn anticholinergic side effects like ABCD. A is agitation, B is blurred vision, C is constipation confusion, D is dry mouth, and S is stasis of urine or sweating. Then we have and common anticholinergics that are very common medications, mostly antidepressant, antihistamines, incontinence, antipsychotics. Antidepressant mostly duocelapin, clomipramidine, doxepin. Then antihistamine can be Benadryl, Alarclor, Atarax. These are all types of the medicines. Destrol, Vesicare, Zyprexa, Seroquel, Trifluperazine. These are antipsychotics. So these are types of common anticholinergics and used in different categories. Now we come to the uses. As anti-secretory effect, pre-anesthetic medication, peptic ulcer, pulmonary embolism, Parkinsonian. Then these are to prevent excessive sweating and salivation. As antispasmodic, intestinal and renal colic, abdominal cramp, nervous, functional, and drug-induced diarrhea. Not useful and effective. I will smaller this photo next time. Spastic constipation, irritable bowel syndrome, pylorospasm, gastric hypermotility, gastritis, nervous dyspepsia may be partially suppressed. To relieve urinary frequency and urgency, ureasis in children, dysmenorrhea, NSAIDs are more effective. Bronchial asthma, asthmatic bronchitis, and COPD. As mydriatic cycloplegic in ophthalmic practice to antagonize muscarinic effects of drug and poison. Anticholinesterase and early mushroom poisoning also it is used. So next is belladonna or atropine poisoning. The what are the symptoms? You can see dry mouth, difficulty in swallowing and talking, dry, flushed and hot skin, especially over face and neck, fever, difficulty in micturition. Micturition is I will tell you later on. A scarlet rash may appear, dilated pupil, photophobia, blurring of near vision, palpitation, excitement, psychotic behavior, ataxia, delirium, dreadful visual hallucination, hypotension, weak and rapid pulse, cardiovascular collapse with respiratory depression, convulsions, coma occur only in severe poisoning. Now we have the treatment. If the poison is ingested, gastric lavage should be done with tannic acid. The patient should be kept in a dark, quiet room. Cold sponging or ice bag are applied to reduce body temperature. Physostigmine 1 to 3 mg SC or IV antagonizes both central and peripheral effects, but has been found to produce hypotension and arrhythmias in some cases. So physostigmine can be used in atropine poisoning. Now there can be contraindications, there can be interactions, and there are many diseases we have already known, like you already saw about pylorospasm, ureasis, cycloplegic, renal colic, and pulmonary embolism. So firstly we talk about contraindications that can be in glaucoma. Caution is advocated in elderly males with prostatic hypertrophy. Urinary retention can occur. Then we have interactions. Absorption of most drugs is slowed because atropine relays gastric emptying. Antacid interfere with absorption of anticholinergics and histaminics. Tricyclic antidepressant phenothiazines have anticholinergic properties, that is additive property. Then side effects can occur with atropinic drugs. So that was all about interactions. Then we have diseases. Pulmonary embolism, PE, occurs when a blood clot gets lodged in an artery in the lung, blocking blood flow to the part of the lung. Blood clots most often starts in the legs and travel up through the right side of the heart and into the lungs. This is called deep vein thrombosis. Renal colic. Waves of sharp, intense pain caused by kidney dysfunction. Acute renal colic is a severe form of sudden flank pain that typically originates over the cost, cost vertebral angle and extends anteriorly and inferiorly towards the groin or testicle. Then we have pylorospasm. Pylorospasm is cause of delayed gastric emptying in young infants. Ureasis, nighttime loss of bladder control or bedwetting, usually in children. Cycloplegia is a paralysis of the ciliary muscles of the eyes, resulting in loss of accommodation. So that was all about anticholinergic. Let's revise it once again so that we have a general idea. So we start with the anticholinergic drug, then we know the definition. It blocks the action of mostly muscarinic receptor. Next we have the classification, two types: anti-muscarinic, anti-nicotinics. We are here talking about muscarinics, that are alkaloids and other substitutes. Then we have mechanism of action. We already know it blocks muscarinic receptor. We saw the total mechanism through the diagram. Then we have pharmacological action. There is a lot of pharmacological action in other different parts of the bodies. Next we have pharmacokinetics. We already know about the atropine sulfate and hyoscine hydrobromide. So that were the drugs given. Then we have side effects. We know the ABCDs. Then we have common anticholinergics. Then we have other uses. Then we have belladonna and atropine poisoning or atropine poisoning. Then the contraindications, interactions, and diseases related to it. So that was all about anticholinergic drugs. I hope everyone would have understood this topic. See you next time.